All right, guys. I think there's a lot of introduction for me, but the one small correction is I didn't do DDU general. I did DDU emergency. That's a different specialty to general one. But anyway, it covers most of what the general guys do from in terms of renal and all abdominal stuff. Our predominant stuff is abdomen, like your echoes and all those stuff. So this is our kind of bread and butter kind of stuff. Along with me, I do have, because I'm actually working on floor today at this time. So I got my ultrasound registrars with me. They're all back here. So it's good time, like they can also listen to the lectures if you don't mind. If there is any noise coming in, that's probably from them. All right, so with that, we'll start on. So there is no questions or something like that. You've been trying to get something in. So I looked at few things like my previous lecture, I had to modify a bit for this session. So it's more in the context of what a DDU exam, if it is going to be in critical care side, would look like, or what do you need to know about in that aspect of it. So I've touched some of previous questions and picked up some topics from the previous questions, not from critical care side, mainly from general and ED DDU side. So we can go through that kind of, in that perspective, we can go through and more clinically relevant renal ultrasound stuff. All right. We're not going to cover like all this full scanning protocol, like how the Medicare is going to bill and this and that and kind of thing. So, and we're not going to go through renal artery assessment like stenosis and this and that. That's a bit more specialized into it, renal artery stenosis. We're going to skip that one for today. And we're not going to go into some contrast enhanced ultrasound side. That's a bit more advanced too. So you can pick those things up down the track. So this is a slide, a bit crowded, but this kind of gives you the previous questions that's been asked in a DDU setup. If you look at it a bit more, like predominantly it's about hydronephrosis and what are the hydronephrosis mimics are, and obstructive uropathy in a broad sense, pyelonephritis, renal cysts, renal mass, renal failures, or in a more general clinical oriented side, more like a flank pains or right-sided abdominal pain, left-sided abdominal pain kind of thing in a pregnant woman or non-pregnant woman, those kind of aspects. That's what the previous DDU and general questions were. So we're going to touch on these main topics today, and we'll see how we go. All right. I looked at, like, when I looked at last night, come across this paper, not a great paper, I should say, but it kind of gives us some perspective of what ICU would potentially want to know when it comes to renal related pathologies. All right. So it's, I don't know, Chinese or something like that. It's a retrospective thing of what they kind of did. So what they looked at is like all these patients, like 400 plus patients, they went back and said who had renal ultrasound and what is the reason why they're doing it. Predominant of them were acute renal impairment. And they found some hydronephrosis and some of the chronic renal impairments, they've actually found some indeterminate kind of, like there's no cause for it, all this chronic renal failure things. And interestingly, UTI, they could actually pick up around 1/3 of them. They can actually find out some kind of cause for that UTIs or complicated UTIs. So that's something we probably should do more in our clinical setup. Quick technique, you can use curvilinear probe on an abdomen preset to do a renal thing, or if there is dedicated renal preset, please use that if your mission's got it. If it's something like a really young child, you could actually get away with a linear probe with a bit more definition of all the renal parenchymal structures. You keep the patient supine, or my preference is either to roll them to one side or the other. So if you scan the kidneys from the back, you kind of get a better image than you're getting it from anterior-posterior scanning, usually. So scan both longitudinal axis of the kidney and then turn around and take some transverse images too. You need both of them to get a good view on. And once you finish with the kidneys and some color Dopplers, we'll go through those things. And then you come down to the bladder. Ideally, you need a full bladder. If not, you might have to fill them up and try again. You need a longitudinal and transverse views of the bladders with volumes and this and that. We'll go through those. All right, so just a quick brush through on some anatomy of the kidney. I'm sure you all know about this. Just a few points that I want to highlight when you're doing ultrasound is, obviously, that's your long axis. Can you see my cursor running around? Okay, good. That's a long axis of the kidney. That's what we're trying to capture in the center of the kidney. So you should see the collecting system coming in, or the renal vessels coming in when you're measuring the length of the kidney. You can't be lateralized. You need to be in the center of the kidney to measure the length. All right, anyway, so that's one thing. So you got a fibrous capsule, which is going to be quite echogenic because of its reflectivity. And you got some hypoechoic cortex below that capsule. And you got more hypoechoic, almost like anechoic pyramids runs in between below that. So this section from the capsule up to these triangular kind of pyramid-shaped pyramids, this tissue is the cortex. And where the pyramids are all running down here, that's your medulla. All right. And you got your sinus or the pelvis area, which has got, again, a lot of fibrous tissues. So it's going to be quite echogenic structure in the center. So basically, you got an echogenic capsule, hypoechoic cortex, almost anechoic pyramids, and an echogenic sinus or pelvis. And in between, you're going to run some anechoic vessels into it. All right. So in terms of vessels, there's only a few things we need to know. These are interlobar arteries, and you got some arcuate vessels, arteries in the thing. Just remember this one, because when you're going to assess some perfusions and resistive indices, this is where we're going to take the sample from. All right, down the track. So we'll go to those things. So move on. So I said, just a long axis of a kidney. Very good. If the marker is on this side, most likely that's going to be your superior pole. That's going to be an inferior pole of kidney. You got your fibrous echogenic capsule, hypoechoic cortex. We got almost anechoic pyramids in there, and you got echogenic sinus or the collecting systems and fibrotic fatty tissues. You can see some kind of streaky, linear, connecting anechoic structures, most likely going to be the collecting system. Sometimes it could be blood vessels. So you probably need to depend on color Doppler to ascertain which is what. All right. So when you want to measure a kidney, you need to measure from pole, like bipolar length. That's what we're interested in, superior pole to inferior pole. This slide particularly like it mainly because, what is this? This echogenic shadow coming from?
You're allowed to pick on people, VJ, if you like.
Oh, nah.
Yeah. How about Ben? Do you want to kick off? Do you know what that is?
I mean, it looks very much like a rib.
Very good. Thank you very much. Rib shadow. It's very hard to avoid these bloody ribs, though, to be honest with you. So sometimes you just let it pass through in the middle. If you can't get don't put the ribs shadows at the pole, rather put it in the center, so you get a sharp poles to measure. If you want to actually ascertain the parenchymal structures, then you need to avoid those rib shadows away. But for measurement purposes, you can put the rib shadow in the center. It's not going to affect your measurement length. All right. So that's why I just wanted to put this picture into it. So it's very technically sometimes difficult to avoid the ribs when you're on a true long axis of the kidney. All right. So once you finish with the long axis, you go transverse views. Ideally, you need to measure your superior pole on a transverse view and the mid or the hilar region of the kidney, and then a slice of your inferior pole. All right. So you just keep going. When you're coming to mid-level, you should see the renal vessels coming inside. So you take a color flow sample on the mid. So you get a long axis measurement. If you want to show some flow on the long axis, that's perfect. So transverse, superior pole, mid, and lower pole. In the mid, show the renal vessels coming in. All right. That's your pretty much basic standard imaging set for kidneys are. And you do that in the same thing on the other side too. All right, then you moved on to your bladder after that. Few normals. Size of the kidney, 9 to 13 centimeters length. I like it 9/11. It's much easier for my brain to remember 9/11. So I just go with 9/11. All right. So, but the interesting bit is that the difference from one kidney to another kidney should be less than 2 centimeters. If you're going to say that one is contracted kidney or something like that, the difference needs to be more than 2 centimeters. All right. So that's what it's. And if you're getting a 2 centimeter difference, how about you just redo it one more time, because you may not be in a perfect angle, or you haven't captured the entire length of the kidney. Probably redo it one more time just to be sure. Renal cortex, as I said, the echogenicity needs to be more than the pyramid's echogenicity. All right, normally. Renal cortex needs to be slightly less echogenic than liver. When you see the liver, the cortex of the kidney, you don't see it in this image. When the liver comes across there, the liver's echogenicity and the renal cortex echogenicity should almost be the same. All right. If the liver is quite bright and echogenic compared to renal cortex, what does it could potentially mean? Fatty liver, usually. The more common reason is the fatty livers. All right, that's the one of the way to find how reflective the liver is. You just compare it to the renal cortex. All right, on the Morrison pouch or the normal EFAST view or something like that, you can actually have a quick look at it. There are other causes.
Sorry, Vijay, can you say that for me again?
Yep. The liver's echogenicity and the renal cortex echogenicity should almost be the same.
Okay.
All right. If you actually go and see a pediatric kidney, like really young ones, all you see is like, yeah, there's a big blob of liver and the kidney tissue, and all you see is just a capsule in between. They almost match the echogenicity. You don't even differentiate it. But when the adult come in, like if you've got a fatty changes in the liver, because fat is quite reflective and it just absorbs like all those things and a lot of reflection going on. So you get a more brighter liver and a dull hypoechoic renal cortex.
Thank you very much. Cheers.
So other causes, there are other causes for liver reflectivity, like cirrhotic livers, like if you got masses and this, and they are reflective too. All right, but anyway, fatty liver is a very common thing to look into it. So left renal cortex and the spleen echogeny. That's another comparison between kidney and the spleen and the kidney and the liver from one side and another. How it should look like. Renal sinuses, I told you about, they are fibrofatty tissues, so it should look nice and bright, echogenic inside. All right, good. All right, move on to cortical thickness. As I said, that's your cortex. The yellow line is the cortex. From the capsule to the pyramid, normal is more than 6 millimeters. If we can't see the pyramids for some reason, which is not uncommon, most of the time we can't pick up this because it's getting more echogenic, the pyramids, then you will lose this kind of transition from hypoechoic to anechoic. You might end up only measuring the parenchymal thickness, all the way from the capsule to the bright sinuses. If that's all you can do, that number needs to be more than 1.5 centimeter. Right. You all know about when the cortex can get thinned out. All right. So that's most of your chronic renal failures are. They all have a cortical thinning. There are multiple reasons for it. We're not going to go into the etiologies of chronic renal failure today. And interestingly, severe hydronephrosis. When the collecting systems are all just pushing against the cortex, you get a thinning of cortical thinning as well. All right, so that's one more reason you need to look into it. If there is anything, just stop me, all right, in between, if there is anything that doesn't make any sense. All right, move on to severe like hydronephrosis. That's probably the first thing you need to look at. Like, so far, normal things. Any questions about it? Sorry.
Just one question about the color Doppler with renal ultrasound. The scale on the image that you showed before was around 18, I think, for the color scale. Is that typical of what you should be using?
You can see that it's a lot of aliasing there.
Yeah.
Can you see that? So technically, you could have probably gone up in your scale a bit.
Okay, but that's around the ballpark, and then you adjust it for the image.
But the idea of showing this one is not like actually trying to show where the directional flow is. Is that on a quick look, is that a flow, first of all? And is this image primarily showing we are in the mid part of the kidney?
Okay, yeah.
rather than what is the actual flow dynamics is.
Okay,
So,
thanks.
yeah, you might have to adjust the scale. I totally agree. Yeah. So, all right, and moving on to first pathology, that's your hydronephrosis. All right, so quick schematic. All right, that's your normal kidneys. So obviously you got a capsule, cortex. You've got your pyramids. Very, very important. You need to know this papillae. So we got a pelvis, major calyx areas, and you got minor calyces, and you got this cup-like papilla where this renal pyramids comes and joins there. All right. If you pay attention to that area, in a mild hydronephrosis, you still retain that collecting system structure. Obviously, it's bloated up. It is filled up with urine, but you're still maintaining your major calyceal system, minor calyceal system, and your papilla is still cup. It's in the concave or whatever the shape is, whatever the direction you look at. We call it as concave for the time being, all right, concave shape. All right, so, but if you come to moderate level, you start the papilla almost getting flatter. And we see the pyramids are all getting squeezed completely. All right, but you kind of maintain your cortical thickness still in your moderate level. But when it comes to severe, you lost almost like the pyramids all been completely squashed against the cortex. You got very cortical thinning as well when it comes to severe. All right, so that's the thing. So there are a few types of grading systems. One is like 5-stage grading system. The Swiss guys use it. I think Swiss or Canadian, one of them. But the clinically relevant method is mild, moderate, severe. Just stick on to this mild, moderate, severe, which seems to be much more reproducible from clinical perspective rather than this 5-stage grading systems. So let's go on, like that's what we've been using. Like, so just go on to this one. All right. So mild, retaining the structure, moderate, the papilla is all getting flatter, but still cortical thickness is good. In a severe, you're getting thin cortical thickness. All right, good. Let's see some images. All right, it's already written there, it's mild. All right, so, but anyway, the pelvis is dilated. You still got the major calyceal system there. You still got your minor calyceal system there. And you can see the cup-like papilla there. So the cup's not flipped the other side down. All right, so we're still going to call that as a mild. All right, let's move on to this one. Pelvis is dilated, major calyceal system kind of minor somewhere there, and the papilla is already flipped to the other side. All right, it's ballooning down, but you got a reasonable good cortex though. All right, we're not thinning it down completely, so we're going to call that as moderate. All right. This almost looks like the cauliflower kind of thing with no cortex thinning, all right? This is typical predominant cauliflower effect, but almost the cortex been completely squashed. So you're going to call that as severe. All right, clear? All right, good. All right, trivia question 1. Is this hydronephrosis? If it is, what grade would you say? Before you want to commit that as hydronephrosis, what else you wanted to do just to confirm that's not one of those mimics?
I'll have a crack at this. I'll kick off, Vijay.
Yeah.
So it's normal size because it's within that 9-11 sort of centimeter area.
Yep.
You look like you've got is the measurement that you'd want around the calyces or at the actual pelvis junction?
What measure?
Yeah, just where your arrow is there. Can you measure the pelvis?
Yeah.
Can that help you?
To see, but to grade it, or what I'm trying to do?
It definitely would only be mild. If there was hydronephrosis, you'd say it was normal or mild.
If at all, anyway, it's going to be mild. All right. But what are the other possibilities you need to rule out before you say that is a collecting system? Is there something else could look like the collecting system there? Obviously, your vessels there.
The blood vessel, did you put the color Doppler on to see if you've actually got blood vessels in there? Got it.
So that's not a blood vessel that we looked at. That is definitely something else, isn't it?
Yeah, got it.
So there's no flow in that structure there. All right, so far good. All right, but if you look at this side of the kidney, this half of the kidney didn't have that problem. It's just almost at the inferior pole, it kind of sitting in that region there. All right. So when I go transverse, that's your whole kidney is. It is kind of sitting in the middle with a roundish structure there.
So that's a cyst.
Possible. Could be, if it is a cyst, what would you call that? It's going to be more like a parapelvic
Parapelvic.
kind of cyst. Or what is another one that could be? This
Could
is
that be a hypoechoic shadow, like secondary to like acoustic shadow, secondary to some calcification?
this one you're talking about, like going down, isn't it?
Yeah.
That's your edge shadows coming in from the kidney. So kind of getting a little bit of a shadow there. I don't know what this is. Actually the pelvis of the kidney, of the collecting system. So this is actually the CT image of the same patient. All right. If you look at it in a transverse image, the whole kidney is pretty normal. So this is just an extra renal pelvis.
No shit.
All right. That's another DD for parapelvic cyst. It's an extra renal pelvis. All right. So if we go back there, it almost looks like it's coming from inside, but the kidney wraps around like that. And the pelvis is just, it looks like it's inside the kidney in a longitudinal view. But if you go on a transverse, you can see that it's actually outside the kidney in that view, like in your CT scan.
What's the clinical significance of that, Vijay?
Nothing. We're going to call that as unnecessarily hydronephrosis.
You just got to make sure you're not calling that as hydronephrosis when it's an extrarenal collecting system.
That's right. It's just an extra renal pelvis. This guy was just last week guy. The
I
pain,
should let someone else answer that question.
pain was on the left side. This thing was on the right side. So luckily it was on the opposite side, so I didn't call it as hydronephrosis. If it is on the same side, I would be quite inclined to get some kind of imaging done. This guy eventually ended up having a CT because the left side had a problem, but that's a different thing. But we didn't call that as a right-sided hydronephrosis because it didn't clinically match. So anyway, so that's one of the things. What about this one? Question 2, is this a hydronephrosis?
I think you're going to need other views because I guess there could be lots of cysts in there.
Very good.
So
All right. Nothing. The take-home point is, yeah, they got multiple cystic areas in the thing, but nothing is communicating in that image. So that's one of the things you need to look at. This is a parapelvic cyst, multiple parapelvic cysts. All right. Why I'm showing all this thing is hydronephrosis looking structures does not mean it's number one, it is hydronephrosis. Number two, hydronephrosis does not mean obstruction to start off with. And vice versa. Not all obstruction would have hydronephrosis too. Around like 10% of renal calculi actually having a stone in the ureteric calculus doesn't have hydronephrosis. All right. So one of the questions, if at all comes up in your exam, would be hydronephrosis mimics. All right. So these are all the possible causes for hydronephrosis mimics. It could be physiological, like pregnancy, especially late pregnancies. Patient who have significant diuresis, like active diuresis going on. Full bladder could have a little bit of a back pressure. Extrarenal pelvis, parapelvic cyst, dilated renal vessels will mimic like a hydronephrotic collecting system. Papillary necrosis, more like an ATN and this and that, they can actually have looks like hydronephrosis, and some reflex nephropathies. Usually those things are long-standing, as I said there before. All right, there are quite a few reasons why you can have. All righty. If in doubt, what are we going to do? If you think it's an hydronephrosis, I'm not really sure whether it's hydronephrosis. So there are a few things you could do to try to crack down whether it's actually hydronephrosis or not. I made up this mnemonics, just doubts. So one of the things is use some color Doppler. All right, that would take off your renal vessels issue, possibly. All right, look at the other side. Are we having a bilateral extrarenal pelvis or bilateral cysts on both sides, or something that's probably not? Look at ureteric jets. I need to warn you about ureteric jets. Anyway, we'll come down to that, but that will actually help you a little bit, but you can't take that as be all end all kind of thing. Ureteric jets are. All right. And look at the bladder for any kind of stones or sludge that could actually be a cause for this hydronephrosis thing. So, or look at pelvis for some tumors or something pressing on the ureters. All right. And actual stones, you can actually look at it proximal ureter or intracalyceal areas or distal ureter, almost at the VUJ level. Or interestingly, you can see the ureter crossing over the iliac vessels at the pelvic brim. Very easy to pick. All you need to pick up the common iliac arteries and vessels. The ureter crosses over, whether it's dilated or not. All right, so that's another spot you can look at it. Oh yeah, I like this question. We had this question in our exam, so I'm just going to put that up here. So I said like late trimester pregnancy, you get hydronephrosis. And which side is it common? Clinical reason is you shouldn't be calling that as hydronephrosis, or shouldn't be doing anything about it. Just let it go. So if you see this, right, left, no preference, or no.
The most recent one here is being pregnant. I think Benny should answer this question. She should know.
That makes me an expert.
Yeah.
What do you think? Right, left?
Is it right?
Why there would be, like, why it would be unilateral? Like, because we're not talking about, like, the renal vein, which is a bit of a cross, but...
Because he's more likely to squish the inferior vena cava.
Yep.
But, I mean,
So is you?
We call C. We call C. Well, we're saying C.
Hey, someone said A. Who said A?
I.
Very good. A. A.
Because don't you give left lateral position during the cardiac arrest to relieve the compression? That means the gravid uterus is tending towards right side. Is it common tendency to fall towards right?
That's right. Number one. I don't think that is the right answer. That's a commonly believed answer though. But we don't, like Rumak say, the book by like diagnostic ultrasound book says the reasons are known. 2/3 of all this hydronephrosis are all on the right side. Right side. So very rarely you see it on the left side, hydronephrosis, or bilateral. The remaining 1/3 is bilateral or left-sided. 2/3 of them are right, just unilateral hydronephrosis, which is very common after almost like 30 weeks. We're talking about 28 to 30 weeks. Not in the early phase. Big tumor in the tummy. Only happens after that. So, right, so all right, let's move on to ureteric jet. I think I need to move a bit faster. You got some ureteric jets here. Where do you look for is the VUJ. How do you find out whether it's an VUJ? You just go transverse view on the bladder. You fan through the bladder till you see something like a small bump that you see 2 bumps come up. It's a VUJ. And you can see the ureter sometimes comes like an hypoechoic line kind of thing through that. It comes in an oblique angle. It just enters into the bladder. You can watch that. So you can see some left-sided jet. That's a right-sided jet. That's a left-sided jet. The both are coming in. We're all sweet, but it's unfortunately not. All right. So you can even see that in 2D. Actually, you don't need a color, but I don't know whether you can see that. There is some jets happening there. There you go. So one. Even in the 2D view as well, but color's much better. Put the scale a little bit down. Don't worry about aliasing in this case. So it's all we need to know is whether there is a jet there or not. All right, so what's the value of these jets? All right, let's go and think. Before I go to the thing, normal, when someone has been well hydrated, kind of thing, you see the frequencies around 2 or more per minute. All right, on either side. But presence of ureteric jet does not rule out obstruction. You could still have partial obstruction, you still get jets. That's number one. Absence of ureteric jet does not always mean obstruction. That means you might be like volume depleted, or you might be looking at a wrong spot to start off with. You're not capturing the jets, probably. All right, so that doesn't mean anything to. In a partial obstruction, interestingly, the jets that come, say for instance, the right side is the affected side, you got a partial obstruction. The left side is normal. you get a very full-on jet on the left side, almost like how the image looked like on this one. This is the right side jet. Let's see that it just shoots all the way up kind of thing. But if you got a partial obstruction, in this case on the left side, you get a very tiny jets comes in. But interestingly, those tiny jets, the frequency of the jets on the partial side is higher. That means you get small jets frequently keep on, but it's letting out the pressure quite often on the partial side. So, but measuring the velocity of people publish papers on velocities of jets, trying to figure out is whether we can identify partial jets based on velocity. That's totally useless. All right, so just eyeball it. If you don't have a jet, then that's you need to call that. So how are you going to call that as an actually absent? You basically need to wait there for 10 to 20 minutes, which we don't have any patience to do that. All right. Or the other option is, at least you need to capture like 5 to 10 jets on the other side, like an unaffected side, and there's no jets on the presumed affected side. Then you should probably call. But having said that, there is significant variation from institution to institution, what the number is going to be, how long you need to wait, and all those things. So there is no clear structure on that.
DJ, I don't think there's been a critical care physician who's waited 10 minutes for anything in their life.
That's right. So I think like it's pretty hard to call that. All right. So, but if you got both side jets, yeah, kind of, they all looks almost the same kind of intensity jets coming out. Yep, you're sweet. That's all you can take that from a jet. All right. So, all right, stones. All right. As I said before, you could see it in the intracalicularia stones. I got a question for someone before that. What is this one? The stone causing stone causing some artifact.
Yeah.
It's a color.
Twinkle artifact.
What is that called?
Twinkle artifact?
Exactly. It's a twinkle artifact. So when you throw in a color on a stone, it causes a twinkle artifact. The exact mechanism is not known yet. All right. There are theories for why it happens. Anyway, so we don't have to go into that one. But that kind of gives you another idea. I got an echogenic stuff there. I'm not really sure whether hitting one of the vessels a bit more perpendicularly causing that kind of shadow, like an echogenic structure, or is that a gas or gas in the kidneys, or is that actually a stone? So you throw in a color, it would probably give you this one. All right, my question wasn't that. My question was, why there is no shadow from the stone? Pin drop silence there.
Because of what it's made of?
What is that? Very good.
Because of what it's made of?
Okay, there is a chance that that tissue, whatever the density of that of the stone, may not be actually denser to cause the shadow. Very good, very good. It's the same kind of gallbladder sludge and the stone phenomenon. All right. Anything else?
Is it because the pelvis is more echogenic than that obstructs the shadow? I'm making it up, but
if it is a shadow, it needs to go all the way down though. It doesn't matter what the structure here is, because you've never seen that structure anyway. You're not seeing that structure. That means the sound has gone through that, isn't it? Technically, in that line of sight, you should not be seeing anything from that. You're seeing this structure. That means there's no shadow. Anyways, that's not the thing. So for a basic thing, anything that needs to shadow, foreign body, stone, something like that, that structure needs to be at least the width of the beam in that spot to cast a shadow. If it is less than the beam's width, you're not going to have a cast shadow. It's a very, very common problem in renal stones. They are quite tiny ones. All right. They only see it like an echogenic spot. It doesn't cast a shadow. All right. But we classically want to see the echogenic focus with the shadow going down to call it as a stone. That doesn't happen in this bloody intrarenal stones because they're tiny ones. All right. Sound wave just goes around it pretty much. All right. So that's why the color is kind of helpful to pick those spots up. All right. So that's your kidney. You got your pelvis and you got a proximal ureter. And you can have some stones in the proximal ureter too. It's not a very good, because the kidney kind of finishing off, you got bowel loops coming in. all the shadows. So that echogenic structure is one of the proximal stones. It's going to be possible too. Or you could see some stones in the VUJ. This is the long axis of bladder, sagittal view. This is the transverse view, or distal longitudinal view, but you got this VUJ stone with a twinkle again. So you could see the stones in VUJ area, or in proximal ureter, all right, or inside the kidney. That's only a few spots that you can see. That's your twinkle from the VUJ stone. That's your ureteric jet. So you still got a ureteric jet, and you still got a VUJ stone. That means it's just a partial obstruction. All right, so you're still getting that one. All right, spotter. I can tell you one thing. These are all pyramids. Pyramids need to be almost anechoic, isn't it? Hypoechoic to the cortex. But the cortex echogenicity is almost normal, but the pyramids are brighter. It's a case of this where you will probably see that when you start scanning kidney quite often, this kind of calcified looking pyramids. They're just a case of nephrocalcinosis. It could be as milder as just an echogenic pyramids, or it could even look like a denser structures. It depends upon how denser the calcifications are. Just want to throw in along with the stones. These people are prone to have multiple stones. These people, so they're going to have some stone diseases and renal colics quite often. Yes.
Okay. The second image, will you call that as a hydronephrosis?
There is some hydronephrosis because these people will block it. Or this is not a shadow from. You can see a little bit of a shadows coming in, but this is all dilated systems. They're all communicating.
Mm-hmm.
That's hydronephrosis. I would say moderate. The cortex will be reasonably okay still. All right. So, all right. Moving on to bladder. All right. And you can do a few things in the bladder. Assess the volume. You can just look at the jets. We talked about that before. You can look for slides and stones and mass, and you can look in for IDCs and stents, positions, and all that stuff. All right. Bladder volume. Obviously, we're thinking the bladder is an ellipsoid structure. So we're going to go with this formula: length times width times height times 0.52. That's what the mission's inbuilt formula is. There are some institutions, they are working on a number 0.75 instead of 0.52. All right, but traditionally, most commonly, it's 0.52. That's the numbers. So how are you going to measure it? On a transverse view, you can take the width, the greatest width fan through, see where the maximal width of the bladder is, and you flip it around to sagittal, and then you go the longest diameter first, and then go perpendicular kind of thing before on the deepest pocket. All right, so that's how you get a volume. You don't go into the notes, normal volumes and this and that. You can see bladder calculi very easily. You've got a large structure casting a shadow kind of thing, or you can have some sludge and stone disease in bladder. Sludge will not, they don't shadow. Stones will shadow. Because it's just imagine the concept of sand versus stone. Because it's more like a grainy structure, the sunbeams that kind of goes through it. So you can see the posterior structures. You still see a lot of posterior acoustic enhancement there, but rather than some shadowing with the stones. Right, so.
Can I ask, if someone's got a fair amount of blood in their urine, sitting in their bladder, will it look similar to that, or will it be completely
different? Okay, what do you think about this one? I got the slide, next one, what you're asking for. What do you think about this one? This is a blood? Can it be a blood? That's a bladder. There is something layering down on the dependent area.
Could that be a blood clot? I mean, is it sort of organized blood? Because, I mean, acute blood would obviously look potentially the same as the urine, I guess.
Exactly. Acute blood will look totally anechoic. Once it starts to clot, it will become echogenic. In this case, it's more like a grainy and moving around structure. So this is almost like small cells. But there could be an acute blood. Yes, possible. Not clotted yet, but it's all accumulating, sedimenting down. Or it could, this is the case of pyuria. This patient had pus coming out from the bladder. So it's all white cells, and cells are all sedimenting down there. All right, so, but look at this. Yeah, before we go into that one, how about I just show you this one? This is what you're asking about, Sam. This patient, what do you think about this bladder?
The echogenic sort of part of the material in this bladder looks more heterogeneous than in the last image that you showed us.
That's more uniform, isn't it? But this one has got like linear anechoic areas in between. What all does this fibrous structures running around?
So that could be fibrin strands if it was blood in the bladder.
Thank you. That's actually a patient with hematuria come in with urinary retention. They had a massive clot in the bladder. That's why we couldn't go in for retention. So obviously, this is a bladder mass. So we throw in some color to see if there is any vascularity to that structure. There's no vascularity, right? So what we did is we couldn't get an IDC for this guy. That's why we just ended up cleaning at the bladder. So you know the wire technique nowadays we do, put a thin wire through it, and then make sure the wire comes into the bladder first. Some jiggle the wire a bit so the clot gets moves around. Then you feed, you'll most like a Seldinger technique, you feed your IDC after that. And you just confirm your IDC position once you got the wire inside. All right, so that's actually a clot. You can see some kind of heterogeneity to it rather than more like a uniform sand-like structures like in the pyurias. So that's a bit different, but it could be an acute blood. I totally agree with Sam in that case. So it's not clotted it kind of thing. So what do you think about this one? This is a sludge.
It looks like your gain might be turned up too much in the back. I'm wondering.
Very good. Anything else could be possible? If I say the gain's okay, it's just for the argument's sake. If I say the gain's okay. Anything else? I need to tell you one thing. One of the person I admire or love is Roger Gent. All right. So Roger Gent is the guy who's he's like a guru in physics. All right. So, and then this is his slide as well. So he has given me a lot of his slides to me. So to use it. So this is one of his slides. Is this a slide? Obviously it's not. That's why I put it on. All right. What else it could be? Can it be a slice thickness artifact? Okay. Imagine like we are scanning the bladder transverse. If I capturing the anterior and the posterior wall that goes around like that in one slice thickness in that thing, so you'll just put that some of the wall in that area. Does that make sense? If you can imagine that. If you're slicing the bladder and then you get this kind of echogenic wall because you got the anterior and posterior wall going down on that, you're capturing that. It's a kind of a slice thickness. So now the question is, how do we prove this is a slice thickness problem, not a sludge? That's what our clinical worries.
Look at it in the opposite plane.
Okay, Danielle, got it.
Still looks like it's there, but I still think it's a gain problem.
That doesn't help it, doesn't it? Now you might be capturing the lateral walls now. In the slice thickness, in this angle, you might be capturing the lateral walls too. That doesn't help. Anything else?
EJ, would you want to scan through the bladder?
Scan it through the bladder means? Can you be clear?
Yeah, as in almost like going off axis. So you're scanning in the same plane, scanning through the bladder with multiple different views. Would that help?
Would definitely help. Would definitely. If you go out of this traditional views, go oblique, you might avoid it. Yes, you might avoid the slight things problems. I totally take it point. Anything more easier than that? More easier, solid proof. You can't argue.
Color Doppler?
Nope. Something more easier than that, Sam. Don't have to think about too much.
Would you flush the catheter?
You're going invasive, non-invasive techniques.
Move the patient.
Move the patient.
Yeah, move the patient and see if it
Move the
moves.
patient to one side. If it is a slight little sediment down on the other layering now. If it's a slice thickness, it'll still be there. Doesn't matter which angle you turn around. All right, just roll the patient. All right, always do it. With ultrasound, the biggest advantage of ultrasound is dynamic maneuvers. right? Which any other modality can't do it. So we need to use that. So anyway, so otherwise, like when you're putting in a difficult catheters, you could probably see that tube IDC coming in. You could use that for that. I told you about the bladder clots. IDC stents, actually, you can actually see the stent positioning when it comes inside, like a foreign body kind of thing coming inside. That would be helpful to look at it. Spot diagnosis again. Oh, we're running out of time. Sam, what's the goal like with your time? Is that all right if I overrun by 5-10 minutes?
Yeah, we got about another 5 minutes. Is that okay?
Good. Yeah.
Is it osseto-ureteric reflux?
Closer. Something actually protruding reflex doesn't. Patient might have a ureteric reflex. Thank you very much. But what is that structure as such? It's got an anatomical pathology too, isn't it?
7-year-old male.
Younger kid, yeah. Obviously, you guys don't see that often, but it's ureterocele. All right. So recurrent UTIs, just think about ureterocele as well. Just like the whole ureter is just protruding inside. Once they got a ureteric jets come out from that, it kind of shrinks down. Pressure goes off completely. All right. So, all right. Moving on to the next. Oh my God. I don't think we'll finish in 5 minutes, Sam. Sorry. So that's your kidney. Okay. So you tell me now in this view, where does this cortex finishing and where is the medulla happening there in that view? In this area. Can you see any differentiation there? Corticomedullary differentiation. Can you actually make it out? Even if I freeze it. I don't know how it can freeze it. There you go. So it kind of lost its corticomedullary differentiation, if you can agree with me. Or I can show you another image. The inferior pole. Can you see some echogenic stuff coming up there? Instead of kidney being completely hypoechoic, if I freeze that, can you see all this echogenic area there? Like a patchy echogenic stuff in the cortex medulla region. All right. So this is all you can see in pyelonephritis. All right. In a nutshell, you may not see anything in pyelonephritis to start off with, unless it's complicated pyelonephritis. Then you start to see a lot of changes with it. Most common, what the rheumat book says, you see all these things in pyelonephritis. The only thing I can usually make it out is this, loss of corticomedullary differentiation on real time. If you get some perinephric fluid, that's good. If you get some gas in the kidney, that's bad. But you will see those gas in the kidneys. But apart from the compression of renal sinuses, I'm not really confident to make those things up. All right, so anyway, so that's just to remember about pyelonephritis. I think you can crack this one easily. What is this one? Kidney, liver, superior pole of kidney.
Cyst?
Cyst, but it's got a lot of echogenicity within the cyst. It's not like a simple clean anechoic stuff. You got some heterogeneous and there's a lot of vascularity surrounding it.
It's a malignancy?
Tumor?
Possible. If it's a tumor, you should see some flow within it. If not, it's an abscess.
Oh.
All right, we're talking about pyelonephritis. Obviously, the complicated factor is renal abscess. All right, from that aspect of it. So it could be very heterogeneous masses coming inside the kidney. All right. Some common elements, just flick through. You can have some fetal lobulations, very, very common in kidneys because they've been embryologically formed like lobules. They're all trying to come together. It's very common. Don't mistake that as a tumor. All right. It still retains the normal cortical structures, but it's quite lobulated. That's normal. You can have duplex system, one collecting system here, another collecting system there, and you got the cortex tissues going in between it. All right, so that's a duplex system. That's normal too. All right, people with ureterocele most likely have duplex systems. All right, so that's a very common congenital thing that goes on. That's a vertebra, aorta. The kidney could be fused and crossing over the midline. All right, so that's usually at the inferior or superior pole, just joined together like a horseshoe. Sometimes you see a big bump on the kidney. That's not a tumor. That's just a normal variant. It's called a dromedary hump. The reason why it's not a tumor, you can see still the pyramids inside. All right, that's the differentiating factor. If you see pyramids inside, that's usually a normal variant. If you're not seeing a big lump going on, you need to investigate it further. All right, cystic lesions, solid lesions, and it's a long way, man. The common common lesions that you see are all cysts. All right, that's the common stuff you see. All you need to remember is just this one classification. That's probably the complicated factor of the whole kidney disease. All right, so that's this. It's called Bosniak classification. This is what universally been used for any cyst. If you see a cyst, look for septations like this. All right. If you don't have any septations or just one septation, thin one, less than 3 millimeter, like a gallbladder wall, they're all fine. No septation, thin septation is fine. If you're getting multi-septated, thick septations, they are bad. They all need investigation. This stuff. 2F means follow-up. These people need follow-up. 3 and 4 are bad. All right, so that's all you need. But size doesn't matter, at least in one place. It doesn't matter how big the size is. It doesn't matter. The cyst is. It's not classified based on the size of the cyst. It's about the architecture. What do you think about this one? Very clean-looking cyst. There's a bit of a shadow. Ignore. Sorry for that. There's no septation between always single simple cyst. But look at this one. Cyst with a lot of septations, complex cyst. So this needs to be investigated further. All right, so simple. So if it's other complex cysts are hemorrhagic cysts, infected cysts, abscesses, the worst part is the RCC can be cystic too, cystic RCCs as well. Polycystic kidneys, I don't think you guys need to worry about it, probably not for us much. Multiple cysts within the kidney, renal failures and dialysis and all those things. You guys need to know about this stuff, but it's very easy to pick it up. Solid lesion, the only thing I need to let you know about the big gun is the renal cell carcinoma. But importantly, what you need to know about is AML. This is an AML, angiomyolipoma. Looks like a snowball, like a white ball in the kidney. It is benign. Don't have to do anything about an AML. But unfortunately, this is renal cell carcinomas. That looks like an AML too. All right, that looks like an AML too, but they all turned out to be renal cell carcinomas. The renal cell carcinoma could be in any form, could be lytic lesions, echogenic lesions, this kind of heterogeneous lesion. Unfortunately, from our point of view, from ED side of it, any solid mass that we see, we escalate it up. Cystic mass, if it's a simple cyst with one septation, I ignore it. Anything else, we escalate it up to look into it. Resistive index, I think you guys need to know about it, not much from ED point of view. All you take it is a pulse wave sample at the interlobar arteries or at the arcuate arteries, all right? Then you get your peak systolic velocity and diastolic velocity. There is a bit of a low resistance flow always in kidneys, all right? So if you measure that one, the resistive index is 0.77 in this case. Normal is somewhere between 0.5 and 0.7, 0.7 being the traditionally accepted number for a kidney, all right? Any resistance more than that is bad, obviously. So there has been values put on for hydronephrosis. There's a difference in patient who have got hydronephrosis will have a higher resistance and this and that, but it's not been very well validated for hydronephrosis. The only place it's of very good value, I think, is your transplanted kidneys. All right, so I think you guys would probably see most of those ones. We don't see that much in ED setup, but if you can see some, if you want to, there's one of the papers that's been published in New England Journal of Medicine, 2013. So their cutoff is 0.8. The resistive index of more than 0.8 seems to have higher mortality with the transplant kidneys. So just remember that one. If you're thinking about transplant kidneys, just try to get some resistive indices. All right, any questions?
And Vijay, for that resistive index, how do you know you're not off axis there?
Very good question. I was just talking about the guys here. Anyway, velocity is angle dependent, but not indices. Resistive index is angle independent. You can mess up with your peak systolic velocity and end-diastolic because your cos theta is not right. But if you actually put it as an index, it cancels it out. So resistive index is angle independent. So because it's a very, very tiny vessel, we're not angle correcting for the tiny vessels, are we? We're not angle correcting. So we're not definitely not in right angle, proper angle. We're not going to be less than 60.
But
So
try and make sure that the image looks as crisp as you possibly can, just to get the best sort of the best borders of the Doppler trace. Is that what you try and do there?
Yeah. This is the high Q, like the machine's calculating the thing. You know where the peak systolic is. Put a dot in there. Put a dot in the end diastolic velocity. You get your resistive index anyway. That's the things. Yeah, because RI is angle independent. That's why. All right. Got only 3 more slides or something like that. Just to quickly shout it out. What is the other thing is? Hydronephrosis or not? Now everyone's question. Now there's a lot of mimics going into your brain. No, that's what I actually want to achieve. So you can't actually say something that's hydronephrosis unless you've gone through that things. You need to throw in a color Doppler. You need to make sure that you're in the center of the thing. It's not a it's not a parapelvic system, but it's not a big communicating system. The only possibility could be a renal artery, renal vessels, dilated renal vessels, which is not in this case. This is actually a collecting system. If I say it's a hydronephrosis, what do you say? What's the greatest?
Mild.
Thank you. Mild hydronephrosis. Good. What are the possibility for this one is?
Cyst.
Yes, complexes. All the DDs for the complexes. Abscesses. Hemorrhagic. Could be a mass. Could be all those possibilities. All right. You need to go through those kind of things. All right. So, and in the clinical context, in the right clinical. You got 2 pathologies. You won't get anything for the first pathology. You'll get something for the second pathology. Sam will buy you a coffee or something.
Is there a stone there, Vijay?
Oh God, you got the coffee bit. There is a stone in there. Technically, if it is an hydronephrotic fluid, you should get posterior acoustic enhancement, isn't it?
Mm.
Instead, you're getting a shadow. So artifacts are really, really helpful to find the pathologies. So there's actually a stone in there. You're right. You're right. So go and nag Sam to get the coffee.
You've recorded this meeting, haven't you?
I don't know.
Yeah, no, good. Yeah, I need some evidence.
All right, last one. Multiple echogenic stuff within the kidney.
Nephrocalcinosis.
Anything else possible?
Could it be gas within the kidney?
Thank you very much. It could be a gas, it could be a calcification, it could be stones. All right, few possibilities again. You need to think about those possible differentials, all right? You can't short it with one thing. What type of cyst it is?
Simple.
Bosniak 1. Okay, thanks. Simple cyst. Yeah. All right, in summary. Technically easy to perform and interpret because it's a small organ and it looks identical to both sides, which makes it easy. All right, so, and hydronephrosis, just use your simple grading system, mild, moderate, severe kind of thing. Don't go to complicated ones. Think about this mimics. All right, hydronephrosis does not mean obstruction. It could be normal for some people, especially late pregnancy and this and that. Pyelonephritis, you're not going to get much out of pylon unless it's complicated pyelonephritis. All right, so, and calculi, look at that specific spots, intracalyceal, proximal ureter, VUJs, that kind of spots where you're going to look for stones. Ureteric jets, it's only an adjunct. You can't take that to the court. Resistive indices, just reserve it for the grafts kind of things, all right, not for regular use. Just remember Bosniak cyst classification and any solid mass, please investigate further. All right, and one more. Did I put the one more in there? Yeah. This is ED brain. You always need to look for anyone comes in with the renal pathology, try to look at aorta for a AAA or something. All this, remember those red flags for flank pains and all those things. One of them is abdominal aortic aneurysms. So keep that in clinical context here. All right, that's about it, I think, guys. So from my end, so I got some reading stuff.
Well, there, Vijay, thank you. That was an absolutely sensational lecture taking us through renal ultrasound. I really mean it. Thank you very, very much indeed. Were there any final questions for Vijay? Vijay,
that was fantastic. Thank you.
Yeah, here. Vijay, thanks very much, buddy. That really is fantastic. I hope we can steal you to maybe give one of these every now and again to the next bunch of DDU guys coming through, because it was brilliant. Thank you very much.
Thank you, guys. See you.
Thanks, Vijay.
Thank you.